So let me just tell you a little bit about my group. I'm the head of the Knowledge Solutions group, CAD and Knowledge Solutions. We have over 200 people worldwide. Our headquarters are in Malvern, Pennsylvania. Of course, we have some people in Europe. We have a large software team of about 100 people in India and people in Israel as well. So I'm going to talk about what I see as, so Usama presented 5 challenges for data mining. I'm going to talk about what I see as 3 challenges in healthcare. And specifically, I'm looking at what is it about healthcare that makes it hard to do machine learning and data mining, whether it be from a requirement from the application point of view, or whether it be something based upon the setting of the setting. So the first one is robustness. Essentially, I mean, this is obvious. It's one thing to build a machine learning system which, does well on a leave one out cross validation. It's another thing to build a machine learning system, or data mining system, have it deployed, used by a doctor in Texas who doesn't know anything about machine learning, and if the system fouls up, someone dies. It makes it a little bit harder and trickier to develop such a system. The second issue is the complexity of medical data, and I'll spend some time on this. And the third is what I believe is very critical, and Usama also mentioned this. Basically, how do we bring knowledge to bear in the task, or basically the medical task of providing decision support to the user, the physician in this case. Analogous to this, not with the direct mapping, there are 3 areas we focus on in my group. And these fundamentally are image-driven decision support, and I'll talk about these, knowledge-driven decision support for the entire patient record, and then, the big buzzword today, which is not really 20 years away as we all think, personalization of medicine. What I'm going to focus upon in my talk are primarily the last 2. How do you do knowledge-driven decision support for the entire patient record and personalized medicine? But having said that, I'm going to lie and talk a little bit about challenge number 1, which actually ties into the first area, robust classification and detection. And essentially the area here is the following. What we're looking at is when a radiologist or a physician is looking at an image, he or she needs support to help find anomalies. Specifically, cancer is a great example. And, the point is to look through a number of CT slices. So CT is a 3-dimensional view of the lung. And you get something like 200 cross-sections. And the point is to look through these, 200 of these, and say, which of these dots is a cancer? And there are several problems of this ilk. The PE-CAD problem, which was posed in the KDD Cup last year, was in fact generated by our group. And there the task was, how do you find pulmonary emboli? These are blockages in the lung that are potentially life-threatening. And obviously, in all these scenarios, the idea is to detect this as early as possible so that you can treat it. And just in case you're interested, that little dot down here is the cancer, not any of the other dots. And so, shameless plug for a talk later, which is why I'm not going to talk about it. This area is actually the most suited to our traditional machine learning data mining approaches, meaning we are very able to convert this into the traditional attribute vector paradigm. So you have a bunch of features, and you have a label, and you want to predict the label. One of the hard issues over here, as I said, is robustness. And what this means is our system must go through a clinical trial before it can be used. So just like a drug must go through a clinical trial and prove effectiveness, similarly, our system must be used in data we've never seen by doctors who, we've provided some training on the system, but we're not sitting there watching over them. And they have to use our system. And the goal here is not standalone performance, which is one thing which we as machine learning people are very good at measuring. The goal is the delta. How much did you help the doctor, and did you do any harm? So this is why. So for legal point of view and obvious, you talk to a doctor, and doctors don't like to ever be told that they're wrong. So it's very important to say that we're aiding the physician. So this must be approved in a clinical trial, and we have a poster here, and which I'll be talking about in a short paper presentation tomorrow, about the challenges we went through in actually deploying this and going through a clinical trial. Took several years, $3 million just to prove the system in a clinical trial. Not quite as heavy as a drug trial, but pretty strenuous, in other words. So that's why I'm not going to talk a lot about the first challenge and go to the second challenge, the complexity of medical data. Now, when you look at a physician, when you go to a physician's office, what's the first thing they do, or what do they do at the end of your visit? They go through and they dictate, or they write down what their impressions were, the history and physical, the diagnosis, the treatment, right? And they don't create this data for the purpose of, let me later have a computer program analyze it and provide decision support. They create this for the purpose of treating the patient, recording what they did, and enabling the billing, which in the US, of course, is very, very important. The other issue is, for all practical purposes, this is extremely high-dimensional data. So if I went to a doctor, he or she would do 5 tests upon me, and if one of you went, there'd be a different set of 7 tests that were done based on your symptoms and your conditions. And literally, there are several 100,000 tests that could be done. So fundamentally, representing this as an attribute vector is not possible. Secondly, the typical data, the key information is not stored in a structured form. It's typically stored in free text, which are the doctor's impressions, etc. So we're not talking here about analyzing medical data, analyzing doctor's handwriting. If anybody figures out how to do that, please let me know. I'd like to invest in that company. But basically analyzing transcribed free text and other parts of the record, and putting it together. The second issue, again, from a machine learning point of view, is that medicine is not knowledge free. Doctors go to med school. They know a lot. There are textbooks out there. They spend years. What we are very good at is, let's take a whole bunch of data. Let's put a lot of information together, and examples together, and learn. In medicine, getting labeled data is getting data is very hard because of the patient privacy issues. Getting labeled data is extremely hard because, we went to a doctor, we were trying to do a study, and he said, yeah, sure, I'll label 10 cases for you, not a problem. And in this scenario where we're talking about lots of information. Yet, our healthcare IT systems are set in the 19th century, not even, let alone the 20th century. Let's take a very simple guideline that's been known since the 1970s. Patients who have heart failure, which is a disease where the heart wall gets weak and doesn't pump properly, should get a kind of medicine called beta blockers. Now this is about a first-year medical student knows this. Yet if you go and look at the national compliance to this, the compliance is under 50%. The reason is not because the doctor doesn't know that patients with heart failure should get beta blockers. It's because they're extremely busy. They have to see dozens of, lots of patients typically the typical time for a doctor to see a patient is 14 minutes. That doesn't seem bad, but that includes seeing the patient, taking the history, examining the patient, coming to a diagnosis, explaining the diagnosis to the patient, prescribing, and then finally writing up your information and creating the billing record, all to be done in 14 minutes.